listen to you today.
Hello, everyone. Thank you for joining us today on our
Oh, I think,
okay,
your mic isn't working well.
The case-based series, ICU care consideration.
Okay, I can start us off then. So welcome everyone to session 6 of Dr. Rachael's oxygen therapy and critical care case-based series. Today's topic is basic ICU care considerations. Thank you for joining us. As usual, we're so grateful to have Dr. Rachael Kimani Njeri from, the title here is wrong, from Embagathi County Hospital in Kenya. And Dr. Eunice Nagatia Baluma from Tigoni Hospital. And so as we go through the session, you're welcome to share your questions and comments in the chat box. And with that, I'll hand it over to Dr. Rachael.
Thank you, Alana. Good evening, everyone. So I want to welcome you to today's series. Basic ICU considerations is what we're going to discuss today. So I'd request, should you have a question, you can put it in the chat box. Items that will be shared will then at the end of it all give you the links of where you can get the information from. So we'll immediately start. I'll be conducting this session with Dr. Eunice Gatia, a colleague who works in Tigoni. Myself, I'm in Bagathi. So welcome once again, and I think we can start. So today's session is part 6 of the oxygen series. And we're having a discussion on basic ICU care considerations. So what we're going to discuss around is a patient, a 46-year-old man who presents with hypoxemia and respiratory distress. So we're just going to discuss about this patient in various chapters. So our practice change objectives at the end of it is to identify the minimum standards of an ICU unit, intensive care unit, identify the key healthcare providers in an intensive care unit, discuss the types of monitors needed in an ICU, list the specialized equipment needed in an ICU, list the most common indications for ICU admission, understand and prevent the most common complications that occur in ICU patients, review or develop and implement ICU care bundles for each and every ICU that is represented here. So our case example, we could go down. So we have a patient who is 46-year-old with history of obesity and type 2 diabetes mellitus who presents to the emergency department with after 3 days of shortness of breath, cough and fever. So on examination, he appears well. His breathing is non-labored and he's speaking in full sentences. Past history, he had a laparoscopic, that's past surgical history. He had a laparoscopic cholecystectomy done in 2012. Social history, does not smoke, drink, or take any drugs, lives with multiple family members, works in an office as a water engineer. So his vital signs, his heart rate is 98, blood pressure is 127/63, respiratory rate is 30, temperature is 36.5, is a febrile, saturations are 87, they are slightly low. So what's the plan? So this patient is placed on a non-rebreather mask at 10 liters per minute and his SpO2 improves to 92%. The emergency room physician places a call to the on-call ICU physician. So the first question we have to think about is, why did they call this the ICU physician? So to understand this is, what is an ICU? What does an ICU entail? So basically in an ICU is where you want to manage critically ill patients who have life-threatening sicknesses, so or illnesses. And in an ICU is where you want to offer adequate monitoring to the patient. You want to have adequate monitoring. You want to always examine the patient every 4 hourly in the ICU. It can even be hourly, depending on how critical the patient is. It is a unit that should be fully equipped and has all the necessary equipment that are required to ensure that the patients are well managed. So ICU is basically where you manage life-threatening illnesses and has adequate monitoring. So critical care is a moment in time. It is a delivery of care that is time critical. So it basically, every minute counts, and how you manage the patient will improve your outcome. So practice change action item is to identify the minimum standards of an ICU. So according to the World Federation of Intensive and Critical Care, it says that an ICU is an organized system for the provision of care to critically ill patients that provides intensive and specialized medical and nursing care, an enhanced capacity for monitoring and multiple modalities of physiologic organ support to sustain life during a period of life-threatening organ system insufficiency. So which of the following are standard components in an ICU? I believe all of us have probably worked in an ICU, so you could just indicate what is available in your facility or what you've come across. I can give a second to this. You can indicate what is available in your facilities. Okay, so in view of time, so what you can end the poll. Or could people be having a challenge? Let me see. Alana, is it available to everyone?
Yeah, I mean, it should be available. I think maybe people just aren't clicking, aren't using it.
Let me just pick one from the crowd to tell me. Damaris Mugone, is it visible on your screen?
Yes, it is, Dr.
Okay, thank you.
Okay.
So I hope it's visible in everyone else's screen. So at least that will help us be able to evaluate and see what's there. Maybe you can take the poll. I can give another second.
There we go. I think people are using it now.
Yeah, they're using it now. We have 3 more who would like to participate before we end it. Okay, I think the poll has ended. So all of you said all of the above. So yes, in the ICU, you have continuous monitoring of the patient. You have specialized trained healthcare providers. You probably have your critically trained ICU trained nurses or even ICU trained physicians. You have system for delivery of time critical care. So it's should there be any necessity or any need for a patient to be managed, or the condition has changed at one particular moment, then a decision needs to be made as fast as possible so that we can be able to offer the care that is required for the patient at that particular time. You need specialized patient care equipment. Those are the ventilators. You need special types of ventilators that are required in the ICU. You need rapid access to diagnostic and therapeutics. Probably have a portable X-ray or portable ultrasound, and also having a lab that is dedicated to the ICU available at all times and fully equipped, ready to do basic investigations when need arises. So all of the above was what is required. So I think I can invite Dr. Ngatia for this one.
Okay. Hello. Yeah, I'm here. Sorry, I might not be able to use my video today. So I'll take us through the next part. So for the patient whom we've just discussed, so a case update, despite the 10 liters per minute of oxygen by non-rebreather mask, Mr. T's SpO2 decreases to 89%, and his respiratory rate has increased to 32. He's only speaking 2 to 3 words at a time, and initially he could speak complete sentences. Does this patient need ICU? Why or why not? Maybe you can just put a small brief in the chat box, and then we see a quick one. Why do you think this patient needs ICU, and why? Just let me give a minute. Anyone? Does everyone have access to the chat box?
No. No.
Oh, okay. Okay.
Oh, who doesn't have access?
Maybe I've seen, thank you. I've seen someone has been able to respond. Yes, he does. He has features of respiratory failure. Good. Okay. So as we've noted, for this patient, initially the patient was able to speak complete sentences. Now he's only speaking 2 to 3 words. His respiratory rate has also increased, and also his oxygen saturation has gone down. So it's true, this patient needs ICU care. So the next bit of the question, we can scroll up. Which of the following essential staff which of the following are essential staff for an ICU? So kindly participate in the poll. I hope it's available to everyone.
Yep.
Okay, good. So just see which of the following are essential staff to an ICU. So just let's see your answers so that we can be able to discuss. Okay, I can see most of the people have answered, and we can stop. So we can see most of the people have said, actually everyone has said all of the above. So it is true, in an ICU, we'll need ICU trained nurses. we'll need ICU trained physicians, we'll need the respiratory therapist and physiotherapist, pharmacists, cleaning and janitor staff. We even need actually much more, even people like nutritionists. ICU is a complex place where you will need a lot of input and manpower. So all of the above is correct. Which of the above providers could improve the care of Mr. T, and how and why? So in the above ICU providers that have been listed, which of the above providers could improve the care of Mr. T? Maybe just write it quickly in the chat box and write why. Okay. I can click on anyone. Maybe Daniel, you can tell us. I can see your mic is on. Maybe you want to say something.
I've got some problem in trying to find out where the chat box is.
Okay. There's a button at the bottom with 3 dots written more. So when you click that, 3 dots after this, yes, and then click there, you'll see chat box.
I click the third one. 1, 2, 3, the third one, eh?
Yes.
Okay.
Oh.
Okay, so
I think-
maybe in the yes.
Okay, I was saying,
Yes.
if I pick like one person like ICU trained nurses,
Yes.
they will improve the care of Mr. T because they are trained in handling the patient, means the nursing care, the turning of the patient. Patient may not develop other sepsis like pressure sores.
Yes.
That is an example for the ICU trained nurses. Yeah.
Yeah. So for this patient, everyone in ICU has a specific role that they play towards making the patient's life more comfortable and actually improving the outcome of the patient. So all these people have a role in ICU, and they can actually make an impact in Mr. T's improvement. Okay. Yes. So, Dr. Rachel?
Yes.
Okay.
So the next part is, thank you, Eunice, for that the discussion. Discuss the types of monitors needed in an ICU. So Mr. T is transferred from the emergency department to the ICU after evaluation by the ICU physician. He's placed in an isolation room with negative pressure as a person under investigation for COVID-19. He continues oxygen therapy with a non-rebreather mask, but the flow has been increased to 15 liters per minute. Which monitors should be placed on this patient? Maybe I can give a second. So you have a patient who is in the ICU department, and then he's now taken to the isolation room because of having COVID-19. Then he continues being on oxygen therapy with a non-rebreather mask, but the flow has been increased to 15 liters per minute. This is the same patient that we were talking about earlier on. So which monitors would you want on this patient? Can give half a second to this as you indicate the answers on the chat box. Okay, in view of time, so because this patient initially had low SpO2s and now you've now transferred him to the ICU, you need to monitor him closely. So you need to have a monitor that has both, that will be able to measure saturations of oxygen, measure the respiratory rate, the heart rate, and also probably have one that will measure the capnography. Thank you, Maureen Kemunto, for that. So having a monitor that will be able to measure all this is important so that you're able to see if there's any changes that happen during the stay of the patient in the unit. And it also helps to make judgment and be able to manage the patient. Thank you for your responses. So which of the following is not a patient monitor? Which of the following is not a patient monitoring requirement found in most ICUs? We can take the poll, we can give half a second to that. I hope this is clear for everyone and they're able to answer it. Any more responses? Okay, thank you for your responses. So there's one person who said that none of the above are required, and the majority said that what is not a frequent requirement in the ICU is the transcranial Doppler. So I will go through all of them each at a time. So the ECG, the electrocardiogram, is very essential and it's a requirement in the ICU for most ICUs because you're able to know what rhythm is there currently and you're able to make a diagnosis of the type of rhythm that the patient has. It could be a tachycardia, it could be a supraventricular tachycardia, it could be atrial fibrillations. So you're able to interpret the ECG readings and then make a judgment and make a diagnosis. Pulse oximeter is obvious because here you want to monitor the saturation of oxygen. So anything below 90 or even 85 will now be an indication that this patient needs supplemental oxygen. Arterial blood pressure is important, especially if it's in patients who have had open heart surgeries. So you want to have the invasive monitoring of the arterial blood pressures so that you're able to know when, at what point will you be able to give your ionotropes, or even at what point will you start tapering down the ionotropes. The transcranial Doppler is not a common thing that is available in ICUs, not unless in the West. So it's not really a requirement, especially in our setup, because it's not readily available. A monitor that will measure the respiratory rate is very obvious because you want to know at what point you're getting tachypneic. And maybe at that point when the patient is getting tachypneic, they're getting labored breathing, and then eventually they'll get fatigue and requiring intubation. So we could go down. So the vital signs are 102, heart rate is 102, blood pressure is 117 over 52, the respiratory rate is 32, temperature is 37.5, SpO2 is 91.5. So this is what is happening to this patient. So in addition to those patient monitors that we mentioned, what other types of monitors are needed in the ICU? Which other monitors would you want to add on to an ICU? You can go down. Alana, you can go down. So this is just a document on giving the basic needs that are required in an ICU. No, just clear the basic equipment. So it's just showing the basic equipment that is required in an ICU and how to set up an ICU, and even it gives a brief on how to space and how to have your ICU arranged. So some of the basic equipment that you need is, yes, the ventilators, you have suction apparatus, you have airway access equipment, including a bronchoscope and equipment to assist the management of any difficult airway. You could have a fiber optic laryngoscope, vascular access equipment, monitoring equipment, both invasive and non-invasive, defibrillation and pacing facilities, equipment to control patient temperature, chest drainage equipment, if you have a chest tube in situ, infusion and specialized pumps. These are very important because if you want this patient sedated, probably on midazolam, you're going to need an infusion pump. Or if you want to, if the patient is hypotensive and you need to give your inotropes, for example, noradrenaline, you need a pump that will be able to offer the drug according to how you set it. Portable transport equipment, specialized beds, lifting and weighing equipment, and access to ultrasound for placement of intravascular catheters. A portable ultrasound is also important. Other thing that you can have in the ICU is a portable X-ray to be able to do your X-rays on at the bedside. So you could have other specialized diagnostic and therapeutic procedures, like if you have a patient who has renal failure, so you need renal replacement therapy. So you always have your dialysis equipment available. If you have also you can also have intra-aortic balloon counterpulsation, echocardiography, extracorporeal membrane oxygenation, which can be available in the ICU. So we could kindly go back. So there's bedside nursing, standard patient monitors, monitoring of equipment and monitoring of patient transport. So what is the recommended maximum nurse to patient ratio for critically ill patients? The recommended ratio is 1:2, meaning that for every, okay, sorry, I could take the poll. Majority, there's some people who are saying 1:4. So what 1 means is for every 1 nurse, they attend to 4 patients. That's what the 1 is the nurse and the 4 is the patients. But in the ideal ICU, it should be 1:1 or 1:2. So for every 1 patient is dedicated to 1 nurse, or in the West, they do 1 patient, 2 nurse, 1 patient, 1 nurse is dedicated to 2 patients. So the 1:2 is the ideal one. 1:4, you'll have really strained that nurse because this patient, the requirements for the patients in the ICU are they can be very needy. This patient needs to be turned, needs to be cleaned, fluids need to be regulated, drugs need to be given. It could be monitoring needs to be done probably every 1 hour. The monitors, the ventilators need to be checked if they're working. The suctioning needs to be done. So 1:4 will stretch the nurses. So the best is 1:2. So what are your practice change action items? Is to list your specialized equipment needed in ICU. So should you be in a facility or in an institution that is planning to have an ICU, have a list of what is required in that, what you'd want to have in that ICU, so that then you can then give it to the administrators and tell them, for this ICU to work, we need ABC, so that we can be able to have adequate monitoring and adequate care for patients. So which of the following specialized equipment is least likely needed in care of Mr. T? So we could answer that kindly. I'll give a second. All right, so in view of time, so the equipment that is least likely for these patients, remember this guy had issues with saturation, the respiratory system was impaired, so you don't need an EVD, an external ventricular drain. An external ventricular drain is usually needed in cases of patients who have a high ICP, could be cerebral hemorrhage. So at that point, you put a drain so that you can be able to regulate the amount of blood that you want to evacuate from the brain. So thank you for that. What other specialized equipment is common and helpful in the care of ICU patients? That I've already elaborated in the previous discussions. So I'll then ask Eunice to take over this part.
Okay. So we're going to go through the indications for ICU admission. So list the most common indications for ICU admission. So what are the most common indications for ICU admission? Like, just for example, like this patient, what do you think is his indication to be admitted in the ICU? Maybe you can just put something small, just a quick one, and see why are patients. Actually, I think we actually handled this thing in the last session. Let's see why patients are admitted to the ICU. Okay, so from the resources that our admin is trying to show us, so there are very many indications for a patient to be admitted in an ICU. Like this patient we have is a respiratory failure. For this patient, some will be the level of consciousness. If your GCS drops and the patient requires to have a secure airway, so you will need to admit this patient in the ICU. You can also admit a patient just even for giving inotropes to the patient. So those are some of the indications. Yes, I can see in the chat box, thank you, respiratory distress syndrome, which is true. Respiratory failure, needing ventilatory support, reduced GCS, airway protection, cardio support, which is inotropes, and prolonged sedation post-op. So all those are indications, and I think we covered them in the last session, why we would need to admit a patient and actually the selection of the patient to be admitted in the ICU. I think this resource will be sent to the chat box. Okay, so we can scroll down. So what are the common complications in ICU? So to understand, so this practice change action is to understand and prevent the most common complications that occur in ICU. So Mr. T is beginning to look obviously fatigued. He is less awake. He has labored breathing, and his color is looking more dusky or cyanotic, probably for the black. We're assuming, is he black? You'll see the dusky. So he's asking for help to breathe. His vital signs, heart rate is 102, that is tachycardic. His blood pressure has dropped to 97/51. Respiratory rate has increased to 37. Temperature has also increased to 37.5, and his saturations have dropped to 87%. So what clinical steps should be taken to take care of Mr. T? In view of the new vital signs, what do you think the team in ICU should do? Now that Mr. T looks fatigued, he's less awake and he has labored breathing and he's becoming cyanotic. Maybe just write your answers in the chat box. What intervention would you do if you are in ICU? What would you do for Mr. T?
Intubation.
Thank you. Someone has said intubation, rightfully so.
Mhm.
Yeah, because now Mr. T is going into respiratory failure. So we need to take control of his respiration. So we need to intubate him and put him on mechanical ventilation. Yes, given, okay, yeah, so we are assuming also given the COVID era is also a high risk patient who needs to be isolated. Since his saturation is low, and with the sudden onset of respiratory symptoms, we need to have a high index of suspicion. So he also needs to be isolated. That is true. Okay. So in the case update, as the ICU team attempts to place Mr. T on oxygen therapy by high flow nasal cannula, he loses consciousness. After successful intubation, he is placed on mechanical ventilator. He is now hemodynamically stable and under sedation. He is now hemodynamically stable and under sedation. Next, the ICU team decides to place a urinary catheter and an internal jugular central line for increased venous access, lab draws, and monitoring of central venous pressure. So in this, after we have already intervened, we have put a catheter, we've put a CVC for easy drawing of blood. So the question is, list some common complications that occur in ICU. What are some of the complications that occur in ICU? You can even see the answers have been displayed there. So some of the patients, since we have intubated him, it's very common for patients to get a ventilator-acquired pneumonia. Some get central line associated bloodstream infections. It's very common for patients in ICU, since they're not mobile, they are likely to get DVT and pulmonary embolism. That's why you need to always put these patients on TED stockings and also prophylactically anticoagulate these patients. Because of multiple strains, these patients end up getting antibiotic resistance. So even at times you do cultures and you'll find the patient is resistant to almost all drugs. There is a thing as oversedation. So you can oversedate the patient, so to a point that it will take a while for you to be able to stimulate this patient. At times, the nutritional needs for these patients are not met. So for ICU patients, they're in a high catabolic state. So you need to be able to give them more proteins, high caloric diet as compared to normal patients. Then there's something called post-ICU syndrome, where you immediately you've dealt with the main things that brought the patient. Maybe there are other things that come up later, things like maybe the patient will end up having things like insomnia, got a bed sore in the process, things that are not ICU related at that particular point, but will have to be taken care of later. So these are some of the complications that occur within ICU. And in ICU also, there are so many drugs that are given, so it's very easy to get medication errors in ICU. Delirium is very common. So as we said last, in the other, we're talking about ways in which you can select patients also. This is also one of the ways. You need to be able to put your patient in create a room, an atmosphere where the patient is not always stimulated. The patient can maybe assume a normal circadian rhythm and make sure that maybe at night you give the patient something to help them sleep, because the beeping of the monitors all the time can make these patients become more delirious. Stress ulcers are very common, and that's why we always put these patients on PPI prophylaxis. And of course, due to all these things that are going on, patient can go into sepsis and get multiple organ failure. So those are some of the complications that can occur in ICU. Okay, so we can go to the care bundles. I don't know if Dr. Rachael is ready to. Dr. Rachael, are you okay? There's someone who has their video on. Daniel?
Yeah.
Your video and your microphone is on.
Thank you, Eunice, for that informative session. It was quite detailed. Thank you for the insights. So here we're talking about care bundles. In the ICU, we have plenty of care bundles. You have the central line associated blood care bundle. You have the UTI care bundle. There are very many ventilator bundles. So there are all types of bundles. So what is a care bundle? And each care bundles are commonly used in the ICU. So what a care bundle means is just basically whatever instrumentation, could be a central line that you put on this patient, or a catheter that you insert onto this patient. This is now the bundle that helps you to maintain and to make sure that sterility is top notch, so that an infection does not occur in this patient. And we are very specific, especially in the vascular ones, so the central line associated bloodstream infections, because here you have a central line that is usually inserted in one of the large vessels in the body. And through these vessels, if sterility is not maintained well, infections can really occur, and these infections can be detrimental and can be very life-threatening. So for the central line associated bloodstream infections, there are 5 steps to prevent central line infections. So one, the main thing in any facility, be it in the ICU, be it in the ward, is washing your hands frequently with soap or alcohol. You wear your sterile gloves and your sterile outfits, the hat, the mask, the gown. You cover the patient with sterile drips. You clean this patient, clean the insertion site with chlorhexidine. Chlorhexidine is more superior than betadine. And then you remove catheters when they are no longer needed. So for instance, in this central line, what is approved is that you have a central line for 2 weeks. After 2 weeks, it now becomes a risk to the patient. So then you remove it, and should you then reassess and find out, do you need this central line still? Or is this central line beneficial to the patient? Do you require it? If not, there's no point of putting another one. If they do, then now you put a central line in a different site on the same patient. Go down. There's also the catheter associated urinary tract infections. So there's also a bundle here, CAUTI. So you have your catheter removal, aseptic insertion, use regular assessments, training of catheter care, incompetence care, and planning. So most facilities give a 2-week bundle, a 2-week period for change of this invasive equipment that you put on the patient. Then there's sepsis and septic shock. You can go down. Sorry, my son just came, sorry. So you have the sepsis and septic shock. So you have the 1-hour bundle where there's initial resuscitation for sepsis and septic shock. So the initial bundle is for upon recognition of sepsis. and septic shock. So what do you do when you notice that the patient has maybe sepsis or is getting into septic shock? Measure the lactate values. So you need to know how far these lactate values are, what are the measurements, get your blood cultures, administer broad spectrum antibiotics, begin rapid administration of fluids, 30 mL per kg of crystalloids if the patient is hypotensive or if your lactate is more than 4 millimoles per liter. When you have high lactate levels, what it means is that there's hypoperfusion of blood and the organs are not getting enough blood, hence oxygenation is not occurring. And now we're dealing with anaerobic oxygenation, which is bad. So that's when now you'll have high lactate levels and the lactate accumulates in the blood system. So you want to ensure that that hypotension is overcome by giving adequate fluids, administration of crystalloids. Apply vasopressors if hypotensive during or after fluid resuscitation to maintain arterial pressures of above 65 millimeters of mercury. You could go down. So that is the 1 hour bundle of management of any patient who has sepsis or is in septic shock. So there's also something that we call ICU liberation bundle. Now at this point, you want to figure out, you could go down. That we can send a link on the video, then they can watch at their own time. But there's also the ICU liberation bundle to find out if the patient is ready for extubation or ready to be removed from the ventilator. So one, you need to assess, prevent, and manage pain. So understanding pain and find tools of assessment, treatment, and prevention. Then you also need to try and check on whether this patient is breathing spontaneously. So you give spontaneous breathing trials. So basically you put the patient maybe on spontaneous mode on the vent, or you can put the patient off the vent and see whether this patient has any breaths or is making any effort. Good choice of analgesia, understanding the importance of defining of depth of sedation, choosing the right medication at that point. So it's a point whereby you want to reduce the sedation that you're giving so that now you're able to, the patient is easily able to be awake and then figure out if this patient can be able to sustain his own reflexes and whether this patient is able to breathe spontaneously. Delirium, so you assess and prevent and manage. So understand delirium risk factors and find tools for its assessment, treatment, and prevention. Early mobility and exercise. So ICU early mobility involves more than just position change. Here you have to involve your physiotherapist to come and try and understand whether this patient is able to be able to be mobile as early as possible to avoid contractures or even avoid having other issues like DVT occurring when they're in ICU. And there's also the family engagement and empowerment, because now you need to have the family getting involved in the patient's care. This really, really helps when they have a supportive system and helps in the recovery. So it becomes a whole issue. It becomes an issue of even the family being cancelled and having sessions with the doctors stepwise on how the patient is improving and how the patient is and what are the outcomes that are required. Could go down. So the key topics, we've come to the end of the session. So one of the key things that we want to have at the end of this thing is an ICU is a separate hospital unit staffed by specially trained physicians and nurses who work closely with other specialized staff in care for patients. ICU patients need intense monitoring and support for failing organs, and ICUs require specialized continuous patient monitoring system. They also require specialized life support equipment. They differ depending upon resource availability, local risk factors, and help of local communities. So care bundles are important and can reduce ICU complications. It's something that we call post-ICU syndrome and can be significant and has long-term effects and impacts on how the patient will recover from their critical illness. So institutions should follow the guidelines for ICU liberation, and every institution should have these guidelines and try and follow them. So we've come to the end of the session. Could there be anyone with a question? So that the practice change actions, which you had mentioned earlier on. So I want to invite and see if there's anyone who has a question before we close up the session. All these things that we've discussed, we'll send links, will be available, and this information is available in the Learning Resource Center. Anyone with a question? Okay. So I think we've come to an end of the session. Thank you all for attending. At least I believe everyone has gotten something out of it, has grasped something out of it. Thank you for creating the time. The aim of these sessions is to at least equip us or to capacity building and to help us understand at what point end of care or at what point do you have to offer critical care to patients, and if you do, what is the indication of this critical care? And also noting that critical care is just not in the ICU. Critical care can be anywhere. So having just a basic or even a foundation of all this really helps in managing these patients. So we'll have our next session, which is part 7. It will be next week on Friday. That should be, I think, the 3rd. Yes. And here we'll be defining ARDS. So a link will be sent in the course of the week, earlier next week. So I'd like to welcome all of you to next week's session. And thank you once again for attending. I don't know if there's anyone who wants to say something, Alana or Ogi or Eunice.
Yeah, I'd like to
thank you as well, Alana.
Thank you, Dr. Rachael. Thank you, Dr. Rachael. Thank you, Dr. Eunice, for delivering such an important session. Thank you to all of our participants for calling in and participating in the poll and the chat box. As it says on the screen, if you have questions, feel free to email us or to comment on the chat box. Next week's session is also an important topic on defining ARDS, so we hope you will save that date in your calendars. And then I'd just also like to thank Dr. Anna Crawford from Stanford University Division of Global Anesthesia for her leadership in creating some of this content, and Project ECHO and our ECHO India team for making these sessions possible. And yeah, so we'll hope to see you next week, and take care. Have a nice weekend.
Thank you, and you too.
Thank you, everyone.
Thank you so much. Bye-bye. Have a lovely evening and a lovely weekend.
Thank you, Rachel.